Hi, this is Noriko Salamon. I'm a neuroradiologist. I'm going to talk about the brain tumor imaging. So how the brain tumors are imaged in the on just decades of in the past from the current status. In the early 1920s to 1970s, we did not have any CAT scan or MRI scan to look at the brain itself. So in these days, used to inject air or inject contrast into the vessels to see through those structures, the brain structures, using those vessels or air within the space of around the brain. So these are the days looking at the displacement of the vessels or air to see there are some kind of space occupying region in the brain. Then the CAT scan arrived, able to see the inside the brain. So this is the first generation of the CAT scan, which is very primitive in look, but eventually from the very beginning of the skull and the surrounding structures to eventually you can see the inside the brain structures. That's the 1970s. And then 1980s, the revolutionary thing happened in the MRI scan, which has more detailed brain structures able to see, then visualize more in details, and then that revolutionized the brain tumor imaging. So MRI and CT scan are now the major players in the brain tumor imaging in these days. We always prefer MRI, and why MRI? Compared to the CT scan, which you can see here, this is the X-ray based imaging. So you see the structures like bone, which is much more harder than brain tissue structures. The X-ray doesn't penetrate, so it stays in very bright density. The brain tissues are much grayer, and then the water content, which contains in the ventricles and the CSF space, are much darker. So this gradient of the grayscale, you can just visualize and then see if you have any destructive lesions happens in the brain, we perceive as a low density focus. On the other hand, MRI can give you a much obvious appearance of the imaging findings. You can see the better contrast in the abnormalities. So eventually in this scan, you can see the lesion here, but it's very difficult to perceive, but MRI can be seen much easier. And the MRI, of course, you can see the much more in detail in anatomy. So here's a brainstem. You don't see any internal structures, but MRI able to see the internal structure of this is the red nucleus and substantial nigra here. And then this is one of the sequences called T2 weighted imaging. The water is bright and then tissue is dark. And you can use other type of imaging to differentiate the tissue characteristics. Also, MRI can do physiologic imaging. I'm going to show you data, including diffusion or perfusion imaging to characterize the tissue in the consistency or vascularity of the lesion. So here's the brain imaging on a different sequence. Here it's called T1 weighted imaging to T2 weighted imaging. So T1 weighted imaging, you can see the ventricles in these internal structures, which contains CSF water. So water content is dark in T1 weighted imaging, and then tissue content is much brighter. T2 imaging is on the reverse, that the water content is brighter than the tissue imaging, which is darker. So in disease process, in T1 weighted imaging, we are looking at something dark, and then T2 weighted imaging, we are looking at something brighter. So also the other thing you can do is give intravenous contrast. So it's called gadolinium. Gadolinium is you inject intravenously, and then what you can do is you can visualize the difference in signal intensity, which, for example, the nasal mucosa here, if you give contrast, it became bright. So this we call enhancement. So the similar effect you can see in some more hypervascular content in the brain tissue can change in colors if you give contrast. The same thing like the malignant tumors or some of the tumors which very hypervascular can get enhancement. So that helps you to detect the metastasis, detect the recurrent tumors, for example. So UCLA Brain Tumor Imaging Standard Protocol has hundreds of images we obtain with a different plane. So this is the nose is here, and the back of the head is here. So this is a sagittal imaging. And then here is the axial imaging, and then also coronal imaging. We can also get very thin cut volumetric imaging to reconstruct in many different ways of looking at the tumors. And then also this physiologic imaging, which is called diffusion, perfusion imaging. So the perfusion imaging is give contrast to see the vascularity of the process, and diffusion imaging is looking for the water content within the images. So this can gives you that tissue abnormality is very packed cells or much looser cells, much more necrotic. Those tissue integrity is much in detail, and analysis can be done by diffusion weighted imaging. And then so these are pre-contrast imaging and post-contrast imaging. You can see the vessels are enhanced. So that this contrast technique can help you to detect more tumor imaging. This is the example of the glioblastoma. So you can see that if you give contrast in this mass can be much easy to see because you have this white rim with a central necrosis. So this kind of round shape of the lesion this is a tumor itself. And then you can see the surrounding low intensity signal here, and this is the edema, for example. And then all the structures are a little bit deformed, and those are the changes you can visualize. So that's the detection of the tumor can be very easily done. And then the surrounding structure assessments, how much around tissue around is affected. And then you can see if you have extra lesions, we are looking for this enhancing brighter areas with the contrast. So you can see the contrast can help to detect the lesions. And using T2 weighted imaging to see the extent of the fluid intensity, white areas of the edema. And then so here's the tumor itself. And then oftentimes some of the components of the tumor may not enhance. So we also have to look at this T2 based imaging to see the non-enhancing component of the tumors. In the base of the T2 weighted imaging, which can be seen in the bright signal for the water content characteristics, we also use FLAIR imaging. FLAIR means same thing as T2 weighted imaging, but as you can see, the ventricles and the basal cisterns of these CSF content space the bright signal is gone. Only the lesion is bright. So the normal structures of CSF content spaces, we just kind of shut down the water content, and then you see that only the edema or gliosis or non-enhancing tumor component can stay bright. So this helps you detect the lesions without fooled by the normal structure of the bright signal. So we very often use this FLAIR signal to facilitate to visualize the lesions, because the FLAIR can help to see tumors. So this is a T2 weighted imaging, same patient FLAIR imaging, to detecting this high intensity, which is not as bright as CSF signal intensity. Then it's maybe a little bit difficult to pick up this subtle high intensity, but if you use FLAIR imaging, this high intensity can just stand out. So this is the example of the tumors which is not enhancing. So non-enhancing tumor can be malignant, and then those FLAIR imaging is very easy to detect those lesions. This is an example of very infiltrating tumors. So you can see the high intensity in T2 going through the corpus callosum, which is connecting structures right and left hemisphere. And then this tumor is from the left hemisphere to right hemisphere, moving towards extending. And then these features in FLAIR is much easy to see because all the bright normal structure signal is suppressed. Then you have much more darker background, and then seeing the abnormality on the bright signal. The MRI versus CT versus PET scan, which is other modality of the brain imaging. So the PET imaging is something look for the metabolic activity of the tumors. So when you see, we saw the mass in here on the left temporal lobe, which has difficulty seen in the CT scan, but MRI can be easily seen. If you use a PET scan, you see these bright areas. This PET scan can be telling you the metabolic activity of the tumors. So these superficial areas have very bright signal here, and this activity can tell you there is some metabolic activity going on, which characterizes the tumor. Now you have a medial to this, there's some other extra activity here, which is not being detected by the MRI. So there's another tumor here hiding within this bright signal, because this component of the tumor and then this tumor is a different characteristic. So this tumor is non-enhancing and hidden inside this edema. So the PET was able to help to detect these tumors within this hidden activity. So if you go to a surgery, just removing only this, you're just leaving this component of tumor behind. So we always assess, make sure that all these areas of abnormalities is not only the edema, but also the tumor is hiding. And then those modalities can help to identify something invisible area of activity. So the PET scan is you inject the tracer to captured into the brain cells, and just wait for a couple of minutes to get to the scan, and then so the PET scan can able to visualize the injected tracer to be able to engage into those tissue abnormalities. So we use all these multimodality assessments in the pre-surgical stage, and then you do a surgery. So this is a pre-surgical imaging, and then we just able to detect this tumor, and then I'm able to assess the amount of the edema. There's nothing else on the other hemisphere, but in this medial to this, there are just some small area of abnormalities. And then so this is a post-surgical scan. So you can see the resection cavity here corresponding to this region, and plus in the small medial to it, this area. So they detect, able to resect the whole areas. So if you do a post-operative imaging, you can see the hole and cavity where the tumor was resected. And then also have some kind of heterogeneous tissue abnormalities after the surgery. And then one thing different is you see that the mass was pushing these central midbrain structures, and then this effect, the mass effect, is a little bit decreased after the surgery, for example. So this deformity of mass effect is continued to decrease after the surgery. So this is immediate after the surgery, and this is several months later. So then what change is you see the dissection cavity became smaller, and then edema, which was just seen immediately after the surgery, is decreased. So that became much more normal looking brain. And then we look for make sure there is no recurrent tumor around the margin of the dissection cavity, for example. Now, tumor types and grades, and what kind of, when we detect the tumors, if this tumor is what kind of tumor is it high-grade tumors, more malignant tumors versus lower-grade tumors, which is much more slow-growing. In general, higher-grade tumors are more edema, so it is pushing and then affecting much more in surrounding tissues, and then heterogeneous and very ugly looking, and then enhancing with a contrast. So you can visualize as a high intensity structures by contrast imaging. The lower grade tumors are, when you give a contrast, you may not have an enhancement, and then not much of the edema. So those are the major characteristics we can see. And of course, you can have a lower grade look, but could be malignant tumors. So that there's a new WHO classification of the brain tumor in 2021. One of the major things happening in recent years in the tumor classification compared to in the past is they are getting more genetic information into the classification. So for example, glioblastoma is not only the glioblastoma, but also we call the IDH wild type or IDH mutant type, or a different genetic component is added onto the diagnosis. So that's why the tissue sampling is important to define what kind of genetic expression is. And then that's define also the treatment strategies. So the astrocytoma is used to call that low-grade glioma or anaplastic type, etc. But also important to know is this IDH mutant tumor. If it is IDH mutant tumor, the grade will be grade 2, 3, 4. So it could be grade 4 is the glioblastoma, like very high-grade tumors. So it could be a low grade to the high grade. But if you have a glioblastoma IDH wild type genetic expression of the tumor is always grade 4, for example. So I'll just show you this. The new classification includes the genetic information. So this is used to call low-grade glioma, but this is a grade 2 astrocytoma IDH mutant tumors. So here's a T2 imaging, very well defined, no edema, very bright T2 signal, and then post contrast does not have any enhancement. So it's a T2 bright and T1 low, and then doesn't have enhancement. So that may be the characteristic features for the slow-growing tumor. Compared to that, this is a IDH wild-type glioblastoma. Is T2 is bright, but it's very heterogeneous, an irregular shape with a lot of edema. And the T1 with contrast shows this enhancement. So those are the pathology shows this heterogeneity, but that's a very different look compared to the IDH mutant low grade versus this very irregular necrotic wild type GBM. So here's an example of a GBM, but you see that this enhancing mass here with the edema, but also anterior to it, there is some expanded structures here, and then which is not enhancing. So this is a non-enhancing component of the tumor, and this enhancing component of the tumor. Non-enhancing component of the tumor does not have much of the edema. Enhancing tumor causes more edema, but the entire structure changes are this big, not only here. So always important to pay attention to the non-enhancing component of the tumor as well. So here's the typical progression pattern after the Avastin therapy. The Avastin is a very potent treatment medication. So here is the enhancing tumor. So you can see the bright area of lesion in the left insula. And then this one is increasing size. So gave Avastin at this point a day. And then after that, then Avastin can tell you the decreasing the enhancement and decreasing the size of the tumor. So it's very effectively working on this mass. And then, but if you give a follow-up, then the never comes back to this, even you have a recurrent tumor. So that the amount of enhancement can be very decreased, stays decreased. So if you're not paying attention to, it's a very subtle enhancement. So, but it's, as you can see from here to here, enhancement is increased and then continue to increase into the much deeper area. But it's never been a very bright signal intensity. So the entire thing can be very effaced, but you have to very carefully assess the extent of the disease process. When you imaging, importance of the imaging findings is effective, how to the treatment can affect. So the treatment effect can give you a mimic the progression. This is a patient who have a T2 radial imaging, has a lot of edema. Here's a FLAIR, and T2 have the edema, and then post-contrast imaging has like multiple irregular enhancement. So it looks like some bad mass sitting there and then causing edema. And then if we don't have any clinical symptoms, clinical history, we'll call this, or this looks like a GBM. But this is a patient who had a history of meningioma, which is extra-axial mass, not the intraparenchymal mass. So patient had anything in the brain tissue, but outside the brain tissue, he had this dural-based mass, which been irradiated. So the radiation therapy was done in this tumor. So he has this temporal areas can be in the radiation field. So this is eventually the radiation necrosis of the irradiated tissue. So that's the radiation effect. Nothing to do with the brain. Brain tissue is not growing anything. It's just radiating because of the radiation that some necrotic tissue is happening. So the radiation necrosis can give you this ugly edema and enhancement, which mimics the tumor. Is a very important thing to remember. And then if you follow these changes can be subsided, and then you can see the less edema, and then enhancement can be found. Here's another example of the metastasis causing pseudo-progression. So this person has an enhancing lesion in the frontal lobe, which is slowly increasing, and then now it's decreasing and decreasing because he has a radiosurgery on this day. So after this, and then decreasing size, and then all of a sudden, a couple of months later, it became exploded, and then have different features, and then big necrotic mass is formed with a lot of edema. And then this is going to slowly decreasing in the amount of enhancement. So this is a radiation necrosis. So you see the radiation was done here, and then just kind of some effect is happening, but eventually the surrounding tissue necrosis happens later on. So when you are looking at this, and it looks like an increase in size of the tissue itself, but eventually the mass is treated, but surrounding also irradiated tissue became necrotic. So those are the one phenomenon we really have to be aware to not to mistake that this is a progression of the disease. So one of the way to differentiate this to be a progression versus pseudo progression is you can do a activity of this process. If it is a progressive disease, you can have an increased perfusion or increased metabolism. So either you can do a PET scan or cerebral volume and perfusion scan to differentiate those. So these ring enhancing things can be glioblastoma, but there's many different disease processes can mimic those. So this is a metastasis, this is the neurocysticercosis, this is the abscess, this is the GBM of the thalamus, this is a multiple sclerosis, and this is the lymphoma, and this is an abscess. So everything looks very similar imaging features, but there are many things can be a cause of this. When you're looking at recurrent disease, it's not always looking at the lesion of the resection, but also a distant area can have a metastasis or new lesion. So always have to look at the entire brain. And then also you can see that lesion could be multifocal. So either the surgical area is one area, but it can happen in the other hemisphere as well. This is one of the other Avastin effect. So you can see the big edema, high intensity lesions in the before the treatment. If you give Avastin, this edema can become completely nothing, and then you can see the little core of the non-enhancing tumor appears. So Avastin is very effective to treating those extra edema, and then after the edema is gone, you see these high intensity areas can be a non-enhancing tumor. Enhancement itself can be modified by the Avastin, so you can see that all this resection cavity here, and then you have an extensive enhancement of the bright areas. And then if you give Avastin, you see those most of the enhancement can be decreased, but you can still have this small area of enhancement. So we pay attention to look at all these entire areas. Some of the lack of enhancement is Avastin effect, which is decreasing the enhancement, but still may have this area of lesional areas. Even you don't have an enhancement, you may have a recurrent tumor can happen in this area. The Avastin can actually go to the necrotic areas. So this is a patient who has been treated with Avastin, and then this tumor is getting smaller and smaller and almost disappeared. But this one, which is not necrotic, which is not affected by the Avastin. So Avastin doesn't really work on this tumor, but in this necrotic tumor, the Avastin was very effective, for example. Also, you see the Avastin can give you the changes in this big left frontal tumors, but so that you may think everything is going well, but eventually, if you pay attention to this posterior portion, there's a new lesion appearing. So you always have to pay attention to the other entire areas that some distant lesion can happen during the course of the treatment, which is working on the one tumor. So the other technique for imaging brain tumors, which is perfusion and metabolic imaging, which may help to differentiate radiation necrosis versus progression of the tumors. Here is the perfusion imaging. So the perfusion imaging, this is after giving the contrast and then calculate how much arriving time for the contrast, and then assessing how much of the blood pool is retained in those areas. So it's called the cerebral blood volume map. So we can just analyze and calculate those maps and then color code it and then superimpose into the brain. So then you have a resection cavity and some hazy enhancement in this patient. And then if you do a perfusion map, those areas are very yellowish compared to the other part of the brain. That means increased cerebral blood volume. So therefore, this component have some recurrent tumor, which may not be easy to identify because it's not like an obvious enhancement. On the other hand, this is like a very irregular enhancement and looks like a recurrent tumor. But if you look at perfusion, there's no increased perfusion at all. And therefore, this is a necrotic tissue. And then eventually this person has a radiation. So this turned out to be a radiation necrosis. So that it even looks very ugly enhancement. Oftentimes those can be a radiation necrosis. And then that modality of the cerebral blood volume can help to differentiate those. Other modality to look for is a spectroscopy. Unfortunately, spectroscopy is not as specific, but this is looking at the spectra other than the water content. So place the box cell to scan 5 minutes in just only that box cell's areas, and then looking for the aminoacetyl aspartate and creatine and choline peaks and lactate peaks, etc. So that can give you, if the NAA is down, that's a neuronal density is down, creatine is just an internal control and cellular energy function. And so creatine always exists, and then choline peak is a marker of membrane turnover. So you can imagine anything neuronal density, neuronal loss can decrease NAA. Anything turnover ratio is increased, its choline can increase. So infection can give a NAA low and a choline high. Tumor can give you a choline high, NAA low. Stroke can give you the same thing. So any brain disease can have a low NAA and high choline. So it's not really a specific thing, but here is an example of glioma areas. You can see the choline is high. So here's the NAA peak is low compared to the normal is NAA is this high and the choline and creatine is this area. So you can see the pattern of normal tissue versus abnormal tissue have this high choline, low NAA, which happen to be a glioma, but it's, if there is inflammation tissue or demyelinating process, very similar pattern of the high choline, low NAA can happen. So not as specific. So always have to rely on to what imaging look like. The F-dopa is we already showed you about the amino acid transport marker. So, for example, you have this hyperintense T2 signal here, which is like a very subtle, but if you have activity of the F-dopa PET, those are the areas which we're going to grow. Eventually, this is the later on imaging showing this lesion became much growing bigger. So this is not just a gliosis or any noise or volume averaging or artifact. This is indeed the lesion is going to grow. So those are the things can be predicted. So the conclusion, MRI is a method of choice for follow brain tumors. T1 with contrast can give you to the well-delineated enhancement if this is enhancing tumor. T2 and FLAIR imaging can show the tumor edema and radiation changes, and also non-enhancing tumor, the FLAIR is very important. It can be difficult to identify non-enhancing tumor, but new MRI sequence as diffusion, perfusion, also global PET scan can help. So the future goal of imaging is to show that drugs are effective even before changing tumor size as seen on MRI. Thank you very much for your attention.